go through a couple of things as shown in the agenda.
Hi everyone. I think Marta is having difficulties with electricity, so I will go ahead and speak about today's agenda until she is back. So we're going to start by the objectives and small introductions, followed by the background and essential adaptations. We'll go ahead and review the essential programmatic requirements and recommendations. We will then discuss 4 different modules related to Family MIAC. The second module will be related to Simplified Treatment Protocol, followed by a Q&A related to the 2 modules. And then we will move on to Module 3 and Module 4. So Module 3 will be the Community Health Workers-led Treatment Protocol, and the Module 4 will be related to Community Health Workers Simplified Toolkit, where we will have a close look at the toolkit, followed by another Q&A, and at the end we will give you some information on how to request technical support, and we will finish by doing the webinar evaluation. I think Marta is back.
Yes, so I'm back. I'm back. Thank you, Rita. Yes, so thank you very much. Before we start, of course, it's very good to introduce the different presenters that are going to be with us today. I'll begin with introducing myself. I'm Martha Nakakande, the TechRRT CMAM advisor. Next, as you can see through the screen, we have the various presenters who I will let introduce themselves. Grace, over to you.
Thank you, Martha. Good afternoon and good morning, everyone. Thank you for joining us today. My name is Grace Fennell. I'm a program specialist at UNICEF, and I work on the team that supports wasting programming. Happy to be here today.
Hi, everyone. Sorry, thanks. Hi, everyone. I'm Emily Keane. I'm a nutrition advisor with Save the Children, based in London.
Pilar, I'll skip over you. Hi, everyone. My name is Bethany. I am a nutrition advisor with the International Rescue Committee based in New York.
And finally, we'll have Pilar.
Hi, here is Pilar Charle. I am the
there's a bit of a connection problem, but as you can see, Pilar is the ICCM coordinator.
Hi, here is Pilar. Thank you. Hi, here is Pilar. I am the ICCM Nutrition Advisor from Action Against Hunger. Thank you.
Thank you, Pilar. Thank you very much to everyone. So briefly, we're going to go through the objectives of today's webinar. And overall, the webinar is really to introduce participants to the new toolkits developed in collaboration with UNICEF, IRC, and partners. And with this, we'll be able to share the background of the community health worker-led treatment and the advantages of the approach in the context of COVID-19. We'll be able to share some of the key program recommendations for the family work approach and also for the simplified treatment approach, in addition to the community health worker-led treatment. It is also an opportunity to introduce all the participants to the simplified toolkit and also provide information on where implementers can find the toolkit and additional resources or support. without further ado, we would like to now get into the presentation itself. But I would like to remind the participants that, again, with this presentation, there are simultaneous interpretation into 2 languages, that's French and Spanish, and you can access that through the interpretation button below your screen, at which point you select the language that is preferred to you. In addition, please put all your questions in the question and answer box. Any questions that come out in the chat box will not be responded to. So please ensure that you use the question and answer box. Thank you very much. I now take the pleasure to invite Grace to take us through the first part of the webinar. Thank you very much.
Great, thank you, Martha, and welcome again, everyone, and thank you for joining us. As we briefly went over the agenda, today we're going to be presenting to you the toolkit on community health workers treating uncomplicated wasting in the context of COVID-19. Next slide, please. So a bit of background on this toolkit. It was developed by a group of partner organizations who were already working on a toolkit for community health workers using simplified tools. You'll see on the screen there are a number of all of the partners are listed. So thanks to the staff at Concern Worldwide, Malaria Consortium, GOAL, Save the Children, Action Against Hunger, the International Rescue Committee, and UNICEF. The toolkit is a result of a collaborative effort of all of these partners who recognize that as there was emerging guidance on adaptations related to COVID-19 and nutrition programming, there would be a need for tools and protocols that would be easily accessible to implementers who are looking to continue providing treatment of wasting and to avoid disruptions to services. The main element of this tool is the focus on treatment delivered by community health workers. While a number of the elements, as I mentioned, were originally developed before the onset of COVID, they were quickly adopted and updated to reflect the guidance that was coming out in terms of how to continue programming without disruptions, but also safety precautions to be taken during the delivery of community services. Next slide, please. So we invite all of you, if you haven't yet, to please visit the website where the toolkit is housed on the state of acute malnutrition. This toolkit is composed of a number of different elements. There's the guidance, the toolkit guidance document that goes over the different components that we'll be presenting today, along with a number of tools such as registers. The job aids are coming shortly, and you will see a number of videos on the website that were all developed to complement what's included in this toolkit. Next, please. So to jump into sort of the meat of what's in this toolkit, it begins by presenting a number of essential program adaptations that are covered, the key core pieces that we'll be covering in the toolkit. The first is training community health workers, ensuring that community health workers receive adequate training, equipment, supplies, and medicines to be able to provide treatment of uncomplicated wasting at the community level. So again, this is equipping community health workers to treat at the community level and eliminate the need for caregivers and families to bring children to the health facilities. The second essential program adaptation is that caregivers are trained and equipped to assess their children's malnutrition status by conducting family MUAC. So we'll go over in the toolkit guidance on conducting family MUAC, and as mentioned, there's additional tools that are linked to this. And I know that there have been already a number of other webinars on family MUAC, and more detailed guidance will be coming shortly. And lastly is the treatment of uncomplicated cases of severe and moderate wasting, simplifying that treatment using a series of evidence-based protocols that combine and simplify the standard OTP program and SFP program treatment protocols. So looking to combine and simplify the treatment of acute and moderate wasting. Thank you very much. Over to you.
Thanks, Grace. So I'm going to now talk through some of the essential program requirements, and just to give some context on where these recommendations come from. As Grace said earlier, there are a number of operational pilots where community health workers were managing uncomplicated wasting at the community level that happened pre-COVID. So lots of these kind of operational requirements and recommendations come from that experience. And also just to mention, this is a global toolkit, and we really recognise that contexts will vary significantly, but we think these are some of the high level considerations that should be taken into account if you're considering implementing community health worker management of uncomplicated wasting at the community level. And one of the guiding points here is really working through and supporting existing systems, so not putting in kind of parallel structures, and also really thinking about supporting a community health worker to deliver these services effectively as well. So the first consideration is around working through an existing community health worker platform or an ICCM platform. And related to that, before we introduce what will in most contexts be a new set of services, doing some assessment of the existing capacity and coverage of the community health worker platform. So this is really to understand what the resource implications would be by implementing this new service, and then really mitigating against any potential risks around overloading community health workers. And there are tools out there such as the C3 tool that can be used for this assessment. The next point is recognising that community health workers can't manage all cases, so they need to have established referral points for those cases they can't manage. So for severe illness and severe COVID cases, a referral point to a health facility, and also a stabilisation centre for a complicated wasting case. There also needs to be provision for community health workers to have essential supplies. And as you'll see on the right of the screen, we've mapped out what we think are those essential supplies, particularly around RUTF and routine medications, as well as other key supplies. And the last point is around monitoring the services. So there needs to be provision for community health workers to be able to record the treatment that they're providing from admission, follow-up and discharge, and having appropriate tools to allow them to do that. Next slide, please. Yeah, so now kind of getting into kind of some of the steps you might take if you're thinking about introducing this service. So the first area is around aligning with national guidance and protocols. So the objective here is really to ensure that these new treatment services for wasting that are being delivered by community health workers align with existing protocols and processes, and that there's good kind of communication, particularly with those working on community health. So the first point might be around initiating discussions with the Ministry of Health and national coordination bodies about the specific simplifications to the treatment protocol for wasting that would be needed for a community health worker to treat wasting. So this could be simplified anthropometric requirements, it could be simplifying and reducing the dosage schedule of RUTF, for example. And once those have been agreed, then having good communication back, particularly with subnational health systems and the health cluster as well, so that there's coherence when it comes to training and messaging through community health workers. As Grace mentioned, another kind of key part of this is around families being able to actually understand their own children's nutrition status. So through the family MUAC approach, really kind of supporting and scaling the family MUAC approach so that caregivers can assess their own children's nutrition status, And then lastly, ensuring that there's adequate training for both community health workers and supervisors in these new simplified treatment approaches for uncomplicated wasting. The last point to mention here, again, because we want to be kind of coherent, particularly for kind of community health workers, there will be adaptations that will have been made to ICCM protocols. So we should also be really looking to align with those adaptations. And there's specific guidance from UNICEF on what those adaptations for ICCM are in the context of COVID. The next slide, please. Yeah, so again, kind of building on this point around having kind of coherence and really ensuring safety, both for community health workers and caregivers and children. It's really important that we align with guidance on COVID kind of prevention and control measures. So some things to consider here would be around IPC measures that are in place and ensuring that community health workers are equipped with the appropriate PPE equipment and trained in that guidance as well, the national guidance. Also equipping community health workers with key messages on COVID-19 so that they can kind of help prevent but also manage COVID, and they know what the kind of key actions are. And then also really anticipating some of the challenges that community health workers may anticipate when they may encounter when they're delivering these services. So having a discussion ahead of time so that appropriate mitigation strategies can be put in place. So the next point is around supply chain. So recognizing that we are talking about treatment services, having the appropriate supplies on hand at the right time in the right places is really key. So there are a number of considerations that we can think about in advance about how we can support a supply chain to try and ensure we don't have any stockouts of critical supplies. So particularly IETF, but also the routine medications and the MUAC tapes as well. So some things that could be considered here maybe around pre-positioning supplies and thinking about what would be needed at different levels, whether that's national, health facility or community level, and even considering kind of what needs to be there at the community health worker's own home in some cases. And linked to that, ensuring that there's very appropriate storage options available for the community health workers. So in lots of our pilots that we did pre-COVID, we would provide community health workers with things like storage boxes to store their supplies. And also really thinking through what supply chain monitoring systems and tools we can provide for the community health workers as well. So they can actually manage these supplies effectively, but also anticipate any kind of supply breakage or any future needs, so that we've got good data to inform those future needs. Next slide, please. And then the last area just to touch on is around monitoring. So really recognizing that monitoring at many levels is a key point of our quality of services. So firstly, thinking about community health workers monitoring of children. So in certain circumstances, if a child isn't responding to treatment or they may be severely ill, a community health worker may actually need to go and do a household visit. But we would want to ensure here that they have appropriate equipment and training to do this correctly, particularly kind of PPE equipment. Again, thinking about this two-way communication, also recognizing that in the COVID context, things change rapidly. So thinking about how we can establish communication between community health workers and health facilities, supervisors. In the case where we have, where it's possible, we would really encourage that community health workers use existing Ministry of Health patient registers and forms to monitor the treatment of children. In the case where the existing forms and registers aren't really available or kind of appropriate for community health workers to use, maybe in the context of low literacy health workers, for example, we have got some simplified registers and job aids that we'll be presenting later that could also be considered. And then lastly, to think about how this information about community health worker treatment can feed up into national reporting systems. So in the case where there isn't an existing reporting system for community health workers, identifying what the key indicators of performance will be for the community health worker part of the treatment programme, and then identifying mechanisms to feed that data into the national reporting systems. Yeah, and I think I'm going to hand over there to Pilar for the next section.
Yes, thank you very much, Emily. I will continue with the presentation. And here we have the first module of the toolkit that has been presented, which is community-led detection and referral to community health workers for treatment. Slide, please. Okay, so the family MUAC as a no-touch assessment protocol. So in the context of COVID-19, caregivers should conduct MUAC, measuring of edema checks whenever their child is unwell. So training and equipped caregivers should continue to play an active role in assessment and monitoring their children at home. So the community health workers will play a critical role in coaching caregivers through the MUAC process. During each treatment visit, they have to provide initial training to the caregivers who have not yet been formally trained on the approach. Children who are receiving treatment of Westin, mothers should be introduced how to conduct the MUAC and edema. And they have to take the MUAC and edema at home once a week. So even if there is something wrong with the children, the mother had to come back to the community health worker place to check if the children is going well or not. So we have included in our tool that whenever possible, community health worker should be supplied with sufficient MUAC tapes to give caregivers their own tapes for use at home. So in the tool, together with this family MUAC that we have considered as no-touch assessment protocol, we have considered the scaling up of the family MUAC approach. Because provide community health worker a safe alternative to with-touch assessment during treatment visit, and also because we can increase early detection of Westin by replacing mass screening and door-to-door screening activities. So for the training and distribution trails to the existing programs, we need to take into account which is the family MUAC approach at the country level. What does it mean? We have included in the tool that, for example, if we have a context that they are already implementing the family MUAC approach at community level, and mother has been trained more than 70% of the total women, we need just to refer all of these women at the community health worker how to use the family MUAC. But if we have other contexts that, for example, just less than 20% of women have been trained in family MUAC, we need really to reinforce this training at community level with the mothers and also with community health workers. All of these examples we have included in the toolkits. Of course, in this first module, if we are going to introduce the family MUAC, we need to monitor this intervention. So, whenever possible, data connection on process and outcome indicators of the family MUAC approach is recommended in order to inform all of the things that we are doing. So I can give you some examples. For example, some outcomes indicators that we need to collect are percentage of correct mothers, MUAC measuring and edema checks, or another example can be an output indicator, number of MUAC tapes that we have distributed, of number of mothers that has been trained. Slide, please. So the second module of our tool is the protocol modifications required to enable treatment by community health workers. Slide, please. So the protocol is based on a series of evidence-based protocols that combine and simplify a standard treatment protocol and is an appropriate adaptation for community health worker, community-based treatment in the context of COVID-19. I think this has been explained by Grace at the beginning of the webinar. So the simplified treatment protocol does not require community health workers to measure height, weigh children, or interpret IUTF dosages. Similar to the standard outpatient treatment, children with a red MUAC, which is mean less than 150 millimeters, and biped edema, should receive amoxicillin during admission. And all the children receive also albendazole. So no other medicaments or drugs will be required or will be given after. So in the tool we have included several cards, and there you can see how implement should adapt the discharge and referral criteria, which is the quantity or IUTF, what is the capacity of the community health workers. But for this second module, what we have to keep, yes, is the things that you can see on the screen. That children aged 6 and 5 to 9 months with uncomplicated wasted are admitted, monitoring, and discharged. But we are going to use just the MUAC or edema. So we are not going to use weight, we are not going to use height. The second important point is the IUTF and the dosage. So we are going to use just one product, which is IUTF for SAM and also for MAM, for severely acute malnourished children and also for moderate. But the difference is that for severely acute malnourished children, we are going to use 2 sachets and just 1 sachet per day for moderate acute malnutrition. And as I have said in the beginning, for admission criteria and also discharge, but the same way, to follow up, we are going to use, yes, the MUAC. And just to keep in mind that in order to avoid maybe complication at the community level, we have to well explain to the community health worker that if the children is severely malnourished, which means there is a MUAC less than 19, it's better to refer to the health facility. As Emily has explained, in this part, we need to have a health facility to refer the complicated cases. Slide, please. Okay, and just to finish with this part of the presentations, we want to share with you also some other research that we have that it has been already shared, or anyway we could have access after this webinar. So we have, the tool has been already in the State of Acute Malnutrition website, so you can have access there. And also we would like to share with you other tools, other materials that has been developed by other partners, the partners that Grace have introduced. There are some guidelines and tools that GOL has developed, and you have there the link. Also, of course, we have the guidelines and the presentation of the UNICEF. We have also other work that it has been done, but Save the Children. And as you know, at the nutrition exchange, there are the discussions, there are many things that you can also check there to continue to have more evidence or to have more knowledge about the simplified tool with community health workers. Slide. So thank you. I have finished with my part.
Thank you very much, Pilar, and thank you to all the presenters thus far. We have a couple of questions. I think it's best we respond to those questions before we continue. I'll present the different questions to different presenters. Maybe the first question I have for Grace is once Aloysius says that studies show there are a high number of clients missed out during assessments with MWAC, making weight for height more effective. In the bid to consider family MWAC, how is this catered for?
Hi, thanks for that question. There's an ongoing global debate between these two approaches. The purpose of this webinar is to introduce where family MWAC is introduced. We know that the MWAC approach will, at the end of the day, reach more children in a more safe manner given the pandemic that is ongoing. Training a caregiver to screen their own children allows for children to be continuously monitored. The question that MWAC misses some children, it also depends on the context and the country. There's a lot of studies that have been done on this that debates the two approaches, but at the end of the day, the purpose is to reach as many children as possible, and we know that MWAC, there are studies that support MWAC identifying more children suffering from acute malnutrition.
Thank you very much. There's another question from Azim. He says, countries like Bangladesh, where CMAM is not approved by the government, which approach should be taken to address uncomplicated severe acute malnutrition at community level?
Yeah, that is a really good question, and something that I didn't clarify at the top, which I will do now, is that we know that not every country will implement every module and every recommendation in this toolkit. These recommendations have to be adapted to what is the context within each country. In countries where CMAM is not an option and delivery by community health workers is not an option, there have to be conversations with the local government and Ministry of Health on how to best ensure that children are being captured at a minimum, what can be done to ensure that children are screened properly and safely. But again, there are different elements of the tool that can be pulled out if not all are relevant. Family MWAC, for example, in some countries is not an option, and so we will be relying more and more heavily on the community health workers. So that's the response to that one.
Okay, thank you. Emily, I think this could be answered by you. If countries continue to use weight for height and MWAC for admission criteria, ensuring strengthened IPC measures, can this toolkit support this?
Yeah, so I suppose here, I think the toolkit was developed really with community health workers in mind, who will be delivering the services. So because of that, and they will be working by themselves, is a really important point, I think, here. So the toolkit has been developed in a way that it's really kind of simple, and we are using a MWAC only approach with this toolkit, and that's because we have got a single community health worker, so it really wouldn't be kind of viable or possible to do a weight for height measurement by a single community health worker by themselves. So I think there could be elements of the toolkit that could be considered in other contexts where different protocols are being used. But yeah, I think that's kind of broadly how we develop the toolkit. But Grace, Bethany, like please add your thoughts to that as well.
Okay, thank you. And another question is asking whether the toolkit is applicable for every country, especially Bangladesh.
I think that goes back to the earlier question. It's important that every country have the conversations with, like I mentioned, our local government and Ministry of Health to identify which program adaptations are feasible and applicable in that country. And there are elements of the toolkit that can be introduced, but it really is important to contextualize what is in this toolkit.
Thanks. Mahmoud was asking how the CHWs store the required supplies at community level. How would they store the required supplies in the community? Maybe Emily can respond to that.
Sure, and yeah, so I can speak to a little bit of experience from some of the operational pilots that we did, again, kind of pre-COVID, but and I think probably Bethany might be able to add as well, but yeah, I think kind of, again, this will be driven by context and what's feasible and available, but in many of the countries where we did implement this approach, we provided community health workers with storage boxes. So there are different ways that this might be considered in different countries. Sometimes they were wooden boxes. In other cases, they were kind of more metallic boxes. Sometimes we would also provide them with locks and other kind of security as well. But yeah, I think kind of really, again, this will be kind of driven by context. So thinking about what is kind of feasible, and also thinking about kind of what the storage capacity needs to be at the community health worker level. Again, considering that there may need to be some kind of pre-positioning, but I think kind of local solutions that make sense and are discussed with the kind of community health workers would be kind of a really key consideration here.
Okay, thanks. Another question, general for all the presenters. Is there any country that has piloted this program? That's the community health workers treating uncomplicated SAM and MAM. Sure, Emily, yeah.
Yeah, so as far as I know, I think kind of most of the operational experience is pre-COVID on this. So there's a piece of work that IRC coordinated, some learning kind of across countries. So some work was done in South Sudan, Nigeria, Malawi, and Kenya, kind of piloting community health workers treating uncomplicated SAM, and in the case of Kenya, MAM as well. And then I think there are other examples, like for example in Ethiopia, where there's an existing kind of large scale community health worker led treatment program as well.
Thank you. Most of the questions are very
sorry.
So I can.
Sorry. Go ahead,
most
Pilar.
of the questions are very operational, and so I'll allow Bethany and Pilar to contribute to all the responses. The other question we have is, what is the best way to train community health workers and also mothers on MWAC? I think I'll give this question to Bethany. What would be the best way to train the community health workers and also mothers on MWAC?
Yeah, so training the mother. So one of the key parts of the module or the protocol that we recommend is that we recognize in some contexts that community health workers will have to be the ones training the mothers or the caregivers on the MWAC and edema assessment process during the treatment visit. So it would very much be about coaching, you know, perhaps from a safe social distance, coaching the caregiver on how to apply the MWAC tape and how to you know, correctly hold it and also to read the color at least. But in particular, I would say that guidance to do this, particularly in the context of COVID-19, is emerging. And some of the resources that Pilar mentioned that are on the State of Acute Malnutrition website include some training resources there and some training ideas in this context.
Thanks very much. We'll answer a couple of few more questions before we continue the presentation. Another question says, if caregivers are illiterate, how do we collect the core data on mark measurement? Bethany, I believe you can take this on too.
Can you repeat the question? Sorry.
If the caregivers are illiterate, how can we collect the core data on mark measurements? I don't want to presume, but I'm not sure if he's trying to ask core data in terms of the actual value of a mark measurement.
Yeah, that's a great question, and something that I will show you part of the recommendation when I go through the toolkit in the next module. So overall, we've developed this protocol in the toolkit so it can be based on using the color of the MUAC measurement only. You can use the numeric and record the numeric measurement, but it can be based on color only. That is the approach that we've used in previous pilot studies where we were able to, CHWs still had really good performance, and we also had good treatment outcomes, you know, in line with sphere standards using just the color bands. So that's possible, and that's part of this recommendation too.
Okay, thank you. Averagely, how many CHWs are required to treat uncomplicated sum and mum cases, and what would be the frequency of follow-up in this situation? Is it weekly, bi-weekly, or monthly? Yes, Bethany?
Sure, I can jump in on that too. So as Emily mentioned, as one of the kind of key recommendations before deploying this approach, we really recommend that you do an assessment or at least make sure you have a really good idea of your CHW capacity, both in terms of where they are located, you know, how many households they serve, and then based on your presumed caseload, you can kind of determine, you know, how busy you think they will be and how many cases they'll serve. Another thing is based on that is that partners, you all are implementing partners can decide, and I will go through this in the next module as well, if you only want CHWs to treat SAM cases or potentially only to treat MAM cases, depending on you know, what the caseload breakdown looks like in your context, or what your resources are available, or what, you know, your local guidance or Ministry of Health policy will, you know, will allow. So that's another thing to consider as well about caseload.
Thanks, Bethany. And this is the last question we'll have in this Q&A, and I'll take it to Emily. The question is saying, how do you define CHWs within this toolkit or within this context?
Yeah, I think we kind of took an approach that this is something, the global toolkit is something that really would be contextualized for different countries. And I think it recognizes that kind of who is considered a community health worker will vary by context and what a definition is. So really the way that the toolkit was developed was to be kind of flexible and contextualized, I'd say. So we didn't come with a very kind of defined picture of kind of what a community health worker could be. We've made provisions for kind of low literacy health workers versus much more kind of qualified or kind of literate, numerate health workers as well. So I think hopefully the toolkit kind of provides that kind of flexibility. And I would just like to say that I realised I completely blanked on one of my previous questions, the question about kind of where this approach has been implemented in the past. Yeah, there's definitely a huge body of experience from West and Central Africa, and I think Pilar might just be able to fill in that gap that I missed. Sorry, Pilar.
Thank you. Please, Pilar, do add on to that question that was asked previously, where in which areas or countries has this been implemented or piloted? Okay, I think we'll have Pilar respond when we come back into the last Q&A. Thank you very much for the responses. There's still a lot of questions. I hope we'll have enough time to be able to go through most of them during the next Q&A. I now take this opportunity to call upon Bethany to take us on to the next phase of the presentation.
Thanks, Martha. So before this Q&A, you were given an idea of what the protocol is and what the adaptations are that would be required in order to implement at the community level. Module 3 in the document actually provides step-by-step guidance for CHW-led treatment. It describes the admission, the follow-up, and the discharge procedures, which again take into account Module 1 and 2, which Emily and Pilar took us through. The guidance also describes how CHWs can use the Simplified Toolkit to provide treatment. So next slide. So for this presentation, I'm not going to go through each step in detail. Please refer to the document. You know, this is there's a lot of information in that document, and so we don't want to take too much time in this presentation. But I do want you to take a look at the job aid on the screen. So this job aid will just give you and CHWs an idea on the key or most important steps that they should take on every visit. So as you can see, we recommend that CHWs and caregivers practice social distancing and implement hand washing or other IPC measures based on your national guidance. We recommend that CHWs assess for symptoms and exposure to COVID because, you know, they are working with these caregivers, and if there is a referral point for a severe case of COVID, it's a good time to identify that case and refer a child or caregiver to the treatment that they need. Under guidance and coaching by the CHW, so again, referring to what they will do with family MUAC, the caregiver will assess for edema, and also the CHW and caregiver can work together to assess for danger signs, because again, this protocol is only for CHWs to treat uncomplicated wasting. So if there is a sign of medical complication, that child would need to be referred. And the caregiver will also assess for MUAC. And then finally, particularly on the first visit, an appetite test will need to be conducted. So again, you can refer to the document for the really specific descriptions of each step, but just wanted to summarize it here. Next slide. Okay. So Module 4 in the document describes the CHW Simplified Toolkit, or the tools which we created to allow CHW-led treatment. So there's 3 important things I want to share with you about the toolkit. So the first thing is that the toolkit is compatible with lower literacy and numeracy levels. It's mostly pictorial based, and it was designed according to human-centered design principles, meaning we did not just develop it in an HQ office, but we developed it in the field and have field tested it with many CHWs in several countries, as Emily mentioned. So Kenya, Nigeria, South Sudan, and Malawi. The toolkit is based on a toolkit that we developed pre-COVID, but have adapted it to accommodate this guidance. And then finally, the last thing to know is that while we developed this toolkit for CHW-led treatment, as Emily described, using this toolkit is not required to implement CHW-led treatment. It's a supplement and it's a tool. We think it is an effective tool for your CHWs. Let's see. Okay, so we're already on the next slide. So again, this is just another mention that the tools can be found on the State of Acute Malnutrition website, along with the protocol document, which is all the modules we've been referencing, as well as some YouTube videos or short video clips, which describe the tools in more detail. Next slide. Okay, so here is the good part. The first tool I want to introduce you to is the treatment register. So in our experience, tracking malnutrition treatment is more complicated than what most CHWs are used to tracking. So for example, a one-time malaria treatment or infrequent surveillance data, that type of tracking is in most cases a lot easier than what we would ask CHWs to record for malnutrition treatment. And that is admission, follow-up, and discharge information. We created 3 register types, all 3 of which are available immediately in English, in French, and as a fill-in text format. So you can actually open the PDF document and replace the text sections only, but you can replace it with your language of choice, your local language or your preference. Although we created 3 register types, you should not use all 3 registers. As an implementer, you will need to pick or select how many registers you want to use. And we developed 3 because we developed 1 SAM-only register. So it allows admission and follow-up for children who are admitted as SAM. We have a MAM register, which allows admission and follow-up for children who are admitted as MAM. And then we have a combined register. And this register can be used to admit either SAM or MAM children. The reason we developed these 3 registers and are giving implementers the option is because we know that some implementers will treat SAM only. Some implementers will treat MAM only. Some implementers will treat both, or maybe they will start with SAM and phase into MAM. So we just wanted to have a couple options for you, and you can read the document to get a bit more background on how to make that decision. So the last thing I want to note about the registers is, although there are 3, they are very similar, and I'll go through the specific differences. In terms of similarities, all the registers use a standard MUAC tape as the only anthropometry tool or criteria. All the registers allow admission, follow-up, and discharge recording for a max length of stay of 16 weeks, which is what we have recommended based on a bi-weekly treatment schedule. And all the registers have space to record the MUAC color, the MUAC measurement, if possible, and the number of RUTF sachets that are provided, and the routine medication that's provided. Next slide. So here is a SAM treatment register as an example. But again, the 3 registers all have are very similar. They have the same sections. So the section that I've outlined in purple is where the patient background information is recorded. So name, age, sex, location, age, I think I said that. The middle section, which I've outlined in orange, is where the treatment and follow-up information is recorded every week. So another thing to note is we intend 1 register page per child that the information will be kept on the same page. And then lastly, the section outlined in blue is where the reason for discharge is recorded. So only one of these icons will be selected when and if a child is discharged from CHW-led treatment. And I'll go into more detail on those in a moment. Next slide. So here's a clearer picture, hopefully a clearer picture of the SAM register, which I've filled in for admission visit, as well as the first follow-up visit. So take a moment and check it out. So you will see that the patient background information is filled. The admission line, which is the first line, is also filled. So this child came, they were assessed for danger signs. It was determined there was no medical complications. They qualified to be admitted as a SAM patient or for SAM treatment. And so the CHW used this register page to admit them for SAM treatment. You'll also notice on the admission line that this child, based on his age, was given amoxicillin. And there is a place where the CHW can record that that happened, as well as, you know, there's a pictorial reminder of the age range. You'll also see that on the next visit, so visit 2, I've recorded, you know, the next follow-up date, but there's no other information recorded because the idea is that that child and caregiver will come back in 2 weeks, and then we will, you know, go to the next line and the next line and the next line. Next slide. So on this slide, I just wanted to show you a picture of the combined register. As I've mentioned, the registers are very similar, except for, in this case, the admission line. If a CHW is using a combined register, it means that they will have to determine, you know, which line to use to admit the child. So whether they are SAM or MAM, for example. I used the same child as an example. So you'll see that I, or the CHW, has selected that the child has a red MUAC. In this case and in the other case, we've written the numeric measurement, although again, we understand that this might not be possible due to either literacy or numeracy, or also due to just perhaps being, you know, there being too much social distance to accurately read the MUAC, the numeric measurement. We've indicated how many sachets the child was given. So 28 sachets, because it's 2 sachets of RUTF per day for the red MUAC or the SAM child, as well as the routine medication that we gave based on age. Next slide. Okay, so the next tool I want to introduce you to is, we call it the Age and Medication Calculator. So this tool was designed to assist CHWs count a child's age, as well as remind them what and how much routine medication they should be given. So we have experience in some contexts where caregivers might not know the exact age of their child, but they do know the date, or, you know, the month that they were born, or the date that they were born, or a specific event that happened at the time of their child's birth. And a CHW can use that information to count out what the child's age is in months and then in years. So the way this tool works is you will see the dots at the top of the page. So when a date or a event is identified, the CHW, in our experience, can use their finger and just move along the dots, counting out the months, in order to then look down and see what medication the child what routine medication the child should receive. So for example, in the first 6 months,
Bethany,
they
you
would
have 2 minutes to go.
Sure. In the first 6 months, they would have no medication would be provided, because technically this child does not qualify for community-based treatment because they are under 6 months of age. Next slide. So this tool or this visual aid is or can be used by the CHW to help them count the number of RUTF sachets that the child will be given based on their MUAC. So this visual aid, you know, the illustration square is not intended to be laid on the ground like what you're seeing in the photo, but it's the same idea. So a CHW can refer to this page and remember, you know, based on a red MUAC or a yellow MUAC, how many sachets of RUTF should be given over a 14-day period. Next slide. Okay. So lastly, in terms of job aids, there is a flip chart for RUTF feeding messages. It includes the normal RUTF feeding messages, which many of you are familiar with, but it also incorporates some messages related to IPC and related to messaging around COVID-19. Next slide. Okay. So finally, before I close this portion of the presentation, I want to revisit the patient discharge outcomes. So as I mentioned, a child will be entered into a register, 1 child per page. Their follow-up information, their admission and follow-up information will be entered. And then at some point, every child who is enrolled by a CHW will meet a discharge outcome. So these outcomes, I've blown them up here, but they're found in the bottom right of the page. They're found on every register. And there's 2 types of discharge outcomes. There's those outcomes which require referral, and they're in the red box on the left. And there's the discharge outcomes which may require referral, but they are generally the typical CMEM discharge outcomes. So just as an example, if a child is enrolled in treatment and a danger sign is identified, that child is discharged from CHW-led treatment. We would ask a CHW to draw a line through the register and refer the child to the correct referral point. Next, if a child regresses, if their MUAC color regresses, so this is based, this is also related to a question that came up earlier. So say, for example, a child moved from red, you know, to yellow, now they've regressed, we recommend that that child be discharged from CHW-led treatment and referred because something is potentially not quite right there. And then finally, if a MUAC does not seem to be improving, particularly if the CHW is going by color only, if it's not improving for 2 consecutive weeks, we recommend, again, that that child be discharged from CHW-led treatment. And then finally, the discharge outcomes on the right in the gray box are, again, aligned with CMEM, discharge outcomes. So if a child misses multiple consecutive visits, we consider that child a defaulter. If a child reaches cured or a green MUAC for 2 consecutive visits, we consider that child as cured. If the child dies at any time during treatment, there's a place to record that. And then finally, if the CHW enters follow-up information for every visit line and has not reached any of the other discharge outcomes, we are assuming that that child is a non-responder or is non-recovered. So in all these cases, the CHW would discharge a child from CHW-led treatment. And as I mentioned, we have videos on our on the State of Acute Malnutrition website that do go into more detail on this, as well as the register in general, and even provide some practical examples of what a CHW might see in a register, over a couple of weeks. So I just encourage you to check that out for more information. Yeah.
Thank you, Bethany. Thank you so much for the presentation. And definitely we have a lot more questions following your presentation. And again, you've already mentioned it. A lot of questions here are very detailed in the operational aspects, and I'm sure you'll be able, as participants, you'll be able to get the responses when you read the toolkit in detail. We're going to go through some of the questions, and time allowing, we'll be able to answer as many questions as we can. I'll begin with the question that talks about accuracies and inaccuracies in data. And this question will directly go to Bethany. How do we balance the new approaches with the workload the CHWs already have? At times, there are already inaccuracies in their data. At what point do we consider this added option effective for survival, growth, and development?
That's a good question. I think it all goes back to something that Emily had shared at the beginning of the presentation, that it will be very context specific, and something that as an implementer or as a Ministry of Health, you would need to do an assessment or feel confident that you know those factors going into or before you start this approach. So knowing what your CHW caseload is, weighing the benefit or the risk of that compared to the need to extend wasting treatment into the community. Unfortunately, maybe there isn't an exact calculation or threshold. I think it would be a very it would require a context specific kind of analysis before starting.
Yeah,
I will just say one more thing with that is the toolkit, the Simplified toolkit, particularly the register. I mentioned this, but we have found it to be very effective in enhancing CHW performance, in correctly following the treatment protocol at least. So that is, that was the purpose of designing the register and the tools, and we do have evidence that shows that they have been effective in gaining good performance.
Okay, in the same line, looking at the registers, there's a question from Michelle who asks, how do the results from the CHWs registers, how are they compiled? Who collects and aggregates that information? Is it the CHW who tallies the information, or is this done by someone else?
Yeah, that's a great question too. So in the places where we have piloted the approach, we piloted the approach in among CHWs who are attached to the existing health system, which is a key recommendation that we have for anyone interested in the approach or in using the approach. So therefore, our CHWs were supervised by, say, either community health extension workers or even implementing partner, nutrition officers, or whatever the supervision, whatever the existing supervision structure was, our CHWs were supervised by them. And in that case, most of the time, if not all of the time, the supervisors were the ones who were tallying the outcomes or tallying the results from the CHWs.
Thank you. This question will go to Pilar because she did present about the family MOAC. The question is, what are the challenges that were encountered in implementing the family-led MOAC approach?
Thank you. Sorry, can you, I cannot listen very well to the question. Do you mind to repeat it, please?
What were the challenges encountered in implementing the family-led work or the family work approach?
Okay, yes, as we have mentioned during the presentation, we have given in the two different examples. We have given in the two different examples. What we have to say is that we have developed this tool for the COVID-19, and we haven't started yet to test it. So, related to the family work, to our understanding, the most important point should be, as I have mentioned before, be able to, you know, to have enough MOAC tape, you know, for the community health workers. So this is the first challenges that we have to take into account. And the second one is how this community health worker can teach or can train directly each mother that is arriving to the community health worker. So now during the COVID-19, it's very difficult to have a training putting all together, all mothers or all the caregivers. So what we are proposing is to have this training directly the community health worker to the mother or caregiver who is arriving to the community health worker place.
Okay, thank you very much. I hope that's clear to everyone. The next question will go to Grace. Has the toolkit been validated or endorsed by Ministry of Health? I'll probably globalize this and say, has it been endorsed or validated by the various governments or ministries of health?
Hi, thanks, Martha. Those are excellent questions. In terms of being validated by the Ministry of Health, this needs to be discussed at each national level. It's not going to be blanket approved or validated by every Ministry of Health. As we've mentioned, a lot of this toolkit has to be contextualized. However, the toolkit was developed and updated based on the guidance that was issued by UNICEF, GTAM, and the GNC, the wasting brief that was released in March. So, and because UNICEF worked on this toolkit, it is validated by UNICEF. There was a question specifically about validation by WHO. WHO and UNICEF are currently developing guidance on the prevention and wasting of treatment in the context of COVID-19 that will be released very shortly. And I believe there is a webinar hosted by TechRRT on August to discuss this new guidance. What I can say, and I cannot go into the detail of the guidance yet because it's not released, is that the guidance that is developed by WHO with UNICEF is that there are temporary programmatic adaptations that WHO will support to ensure continuity of services. And some of those adaptations are reflected in this toolkit. So I would recommend that everyone join in on August 6th, but also be on the lookout for the new guidance that will come out. And this toolkit can definitely continue to be used as a reference and guide to implementing some of that guidance that's developed by WHO and UNICEF. The last question I wanted to, sorry Martha, because it's sort of related, there was a question about shortage of RUTF. We really recommend that UNICEF is working really hard, putting a lot of efforts working with supply division and our teams at both the regional and national level to ensure that there are no shortages of RUTF. But if there are concerns with a specific country, please do start those conversations with your UNICEF office at country level so that it can be escalated. Thank you.
Thanks, Grace. And again, this will go to Bethany. In cases where community health workers refuse to provide the services, and this toolkit is really based on community health workers, how are we then going to ensure that the children with acute malnutrition do get treatment?
Thanks, Martha. That's a hard question. So I also think this will be context specific. One of the recommendations or considerations that we did put in the document is about thinking about that in advance. So thinking about CHWs refusing to provide treatment based on their right to make a choice, a healthy choice for themselves, particularly in the context of COVID. In terms of, in terms of ensuring that treatment can be available at the community level, I suppose if your CHWs or if your health, the health workers that are part of your health system are not providing treatment, or are not willing to provide treatment, that's a bigger problem, that's a bigger consideration or issue that needs to be addressed, I think even before thinking about implementing this approach or using the tools specifically.
Thank you very much. There's still a lot of questions and we have very little time left, but I would like to ask some question that has kept on appearing. There's a couple of related questions in terms of the sphere standard. And the question is, even when we're implementing this toolkit during the COVID pandemic, we still really want to base on the sphere standards? That question I'll probably take to Grace, especially saying that the context within the sphere standards were developed are not necessarily the same as the COVID-19 pandemic.
Yeah, no, I mean, that's a very, very good point, and ensuring that sphere standards are met is important. However, the situations have changed. And again, going back to that, we have to ensure that this is all very contextualized to the realities of what's happening on the ground. And all of these interventions or programmatic adaptations are based on existing evidence. So just recommend that it's contextualized, that they were also developed based on the most current guidance. So I'll leave that there. I don't want to go any further. I'd rather leave it there and just note that yes, sphere standards are important and these adaptations are taken specifically into account based on context and current programmatic recommendations.
Thanks, Grace. There's also a question in terms of vaccination. Measles vaccination, is that included within this key to the CHW do it, or it would happen at the health facility level? Just seeking clarification.
Yeah, I can answer that. So as part of the simplified treatment protocol, we do recommend that, so first of all, we have the key recommendations about using MUAC only, about using a single product at a reduced dosage. What we didn't spend much time presenting on, but was in the table in the slide and is embedded in the document, is that by and large, we know that you will have to adapt the other parts of your treatment protocol to your local or your national guidelines. So things like other types of either routine medication or recommendations during treatment, you would need to you can adhere to that. You can adapt the protocol to adhere to that. So I do know that some countries, or most countries, do check for the measles vaccination at a certain week in treatment, and you can incorporate that as part of the protocol if you want. Other adaptations, while we're on the topic, that can be made are, for example, the default criteria. We've recommended missing 2 consecutive weeks or 4 weeks of full calendar weeks of treatment would be a default, but you can adapt that also to your local or your national protocol.
Thank you. We'll ask only the last question. Unfortunately, we'll not be able to go through all the questions. But as I mentioned, most of the questions can be answered to directly by looking through the toolkit that is shared on the acute malnutrition website. The last question we're going to ask is about the sustainability of the approach. and how sustainable is the CHW approach? Who is supposed to support that cost? Is it planned to be integrated, you know, within the existing health systems or health structures? I think I'll still let Bethany respond to that.
Thanks, Martha. Another good and difficult question. So I will say, as we've mentioned, we have piloted this approach in several countries and different contexts. I will be honest with you, we have not yet tested this approach at large or at national scale. So we are still learning about what operational policy or, you know, human resource structures need to be in place to make it sustainable. That being said, particularly in this context, an emergency context of COVID-19 and potentially of widespread transmission during a pandemic, we feel that this is a viable approach to ensure the continuation of treatment services, as well as to potentially or hopefully reduce transmission that may occur at crowded health facilities, for example. So we're still learning about large and scaled the sustainability implications. But please do stay tuned. Again, the State of Acute Malnutrition website is where we've been sharing the evidence that we've generated on this approach, all of this new guidance that we've developed, and it will continue to be our landing spot as we develop more ideas and evidence.
Thanks, Bethany. Thanks to all the presenters. There's so many questions and I wish we had a lot more time, but we do not. Most of these questions can be responded to by reading the toolkit and continuing discussions within the chat box should the need arise. So we're almost coming to the end of our presentation or the webinar. We, however, thought that as the presenters have mentioned and as Grace elaborated, the situation is evolving. The COVID-19 pandemic keeps on changing. We have guidances and briefs in place. We're also still learning so much and trying to do our level best to get as much as we can from the learning. So we wanted to know from the various participants on what they see as some of the things we can do right now or the way forward following this webinar. Now that we are aware of the toolkit, what do you think should be done next, or what would people want to see happen next? I think that's going to be an open discussion that we can have via the chat box, but also we can have some comments put directly in the Q&A.
Martha, I'd add to that a little bit. I think what we wanted to gather from the participants, as you can see, there is a lot of information in this toolkit, and there were a lot of operational questions. And our idea is to perhaps have a webinar that looks more in depth at some of the different modules of the toolkit, or maybe focuses just on the tools. So it would be great to hear from participants, way forward in terms of how can we make this toolkit more easily accessible, or how can we explain it further, knowing this was we've been an hour and a half, and I think we just touched on the very basics and generalities of the toolkit. So more specifically, moving forward, what would participants see as the most helpful? I know there were questions on translations, which we'll be working on getting those. But yeah, just to hear from you all, what are some webinars that you think would be good to follow up to this webinar, specifically on the recommendations in this toolkit? Thanks.
I'll also jump
Yes,
in,
Bethany.
Martha,
Yeah.
if that's okay. So I put a link in the chat, not in the Q&A box, just to let you know that we also have an ongoing kind of I forget what they're called, a conversation stream on ENN. So if you have any like pressing unanswered questions, you can also post them there. And it may, even help others who have the same question. And we'll be looking at that and monitoring that as well. So just to let you know.
Well, thank you very much. We'll be waiting for the responses on the way forward, and also in addition to the questions on that work stream. We come almost to the end of our webinar, but before we go, we wanted to share with you ways in which you can actually get additional support should it be required. Next slide. Through requesting support from the TechRRT, we can be able to avail remote or in-country technical support, although within the current context, it's mainly remote support. You can also hire a consultant directly. There exists standing pools of consultants within the GTAM for the different areas, including CMAM, IYCF, assessments, micronutrients. You can also ask direct questions through the GNC Global Health desk. Should you have any questions, please do contact us through the link shown below and request for support that you need. Thank you very much. Thank you for the time and effort. We come to the end of the webinar. And once this is done, you're going to be directly taken to a link that requires you to fill out an evaluation of the webinar, and it should take not more than 10 minutes. It's important that we get this feedback so as to better support you. Thank you very much. For any additional information, please do contact the TechRRT via the email mentioned there, and you'll be soon able to access the recording and the slides of this webinar through the website. Thank you very much.